So anyway, tonight I want to be talking about nurturing resilience, courage, um, uh, with kids who have anxiety, and helping parents sort of, really foster that in kids, because they're going through a lot of difficulties right now and transitioning back to school, whether it's hybrid or, in person. So today I'm going to be talking kind of a bit about sort of myself and why I'm here. Really what about how I see anxiety and how I think it will be helpful for parents to see anxiety so that they can kind of understand it more from the child's experience, which I think has really helped me connect with the students that I work with. So I'll tell you a bit about myself. Again, my name is Dan Villiers. I was born in London, moved to the US in 92, 93. And I was definitely, a phobic child. And I guess I started out as shy and then evolved into phobic. And I share this personal stuff because for me, it's a way that I can connect with students. I really struggled with anxiety. There's a lot of background noise in there. I'm not sure if people are on mute, but my anxiety got really bad. I went to sort of high school and I dropped out my junior year because of panic attacks and social anxiety and maybe a lot of the things that you're seeing with your kids. Dropped out, moved back to London, and I went on this sort of exhaustive pursuit to find the right therapist. And this might be a familiar experience for many parents, but I think I saw about 6 or 7 therapists before I found the right one. And it was really that therapist that changed my life. He had a totally radically different approach. It wasn't process orientated. It was very behaviorally focused. He started talking about how to face fears and induce anxiety and things that sounded just horrible and challenging. And because my whole life and world was designed to protect myself from any feeling of dysregulation. I mean, I had it down. I had a way to manipulate my parents. I had a way to make them feel like I was going to even hurt myself, I give them guilt trips, whatever I needed to do to maintain my current place of safety. So without going into my whole life story, I really went from being a patient to eventually a provider. And did my training went to Kenyon College and then Dartmouth, and Northeastern for my PhD. But my real, I guess, kind of most lightning experience in my career was working at Mountain Valley, which was prior to the Anxiety Institute. That was really the first time I got an experience where I could meet these kids where they're at, which was usually at a point of, I've tried everything. I feel hopeless. I feel helpless. The parents don't know what's going on. Is it anxiety? Is it ADHD? Is it depression? Which comes first? And I was fortunate enough to go to about 600 homes in 4 years, all around the country and the world, and meet these kids who typically, but not always, were not excited about therapy. Especially something intensive, which was what I was offering at that time, which was residential. And I had, some good success with that. And I think it was because I really brought my personal experience in there. And also because I wanted to be there as if any of you call me for help with your child. I come to the table as someone who is a consultant wanting to help inform, motivate, inspire your child to get to treatment. It's not about, while I do work in admissions, it's not about admissions for the Anxiety Institute. It's let's help understand the experience of your child, and see how we together can partner so we can get them the treatment they need at whatever level, whether it's private practice, intensive outpatient program, which is what I have, residential. So I serve as that facilitator, and that I'm fortunate in my career to be able to do that because I love it the most. I'm sure a lot of you are familiar with anxiety. It's exploded in the news. I started Mountain Valley in 2010, really on the heels of some data that came out in 2008 that showed that the rates of anxiety increased by about 700% since the invention of the smartphone. So smartphone played a big role in the epidemic that we're seeing today. Now, of course, we're seeing another major problem, which is COVID, which is something I'll address later. But anxiety is, considerably more common today than it was 10 years ago. So I'm going to talk about symptoms of anxiety because symptoms of anxiety occur across all anxiety disorders, whether it was the social phobia and agoraphobia that I had, whether it's the OCD that, a number of my clients have, whether it's the generalized anxiety that my mother has, whatever the diagnosis, there's some experiences and symptoms that link them all. And physical symptoms, you'll be aware of, but increased heart rate, sweating, flushed skin, headaches, choking sensation. And it's on a continuum. So, we rate anxiety. I really encourage everyone to rate anxiety on a 0 to 10 scale. 10 being the worst anxiety one could possibly have, which is sort of at the panic level. 0 is no anxiety, cool, calm, and collected, and I would say 5 is kind of just tolerable anxiety. It's kind of an anxiety you might experience where you can kind of push through, and it will go. What I kind of refer to more, the 3 to 5 range is the more normal anxiety that everyone will have at a certain point in time. What we're talking about today, and the clients that I work with and most therapists work with, is anxiety that's, at a higher level. It started to impact their life, make decisions for them. And so physical symptoms, now these could be physiological symptoms. Sometimes they're visible, sometimes they're not. Mine were very visible, which was very unpleasant, and because it kind of perpetuated the hypersensitivity, hyper awareness of everyone around me, and I can see my reflection in that window, or I want to go to the bathroom and check the mirror, and all of that cycle just fuels the symptoms themselves, and then the fear that comes with it, and then the escape and avoidance that gets wrapped up in that, and that leads us to the behavioral symptoms, which are often and most commonly avoidance. Could be self-soothing strategies. A self-soothing strategy or reassuring. One self-soothing strategy is a reassuring seeking behavior. Is maybe a child asking a parent, asking a parent, how many people are going to be at this party, or what's the weather like? The road's icy, or how do my clothes look today? Asking once is fine. If you ask multiple times, or it's a sign that it's something more kind of to be concerned of. Refusal to leave home, another component of avoidance. I work a lot with kids who have developed school refusal and school avoidance. Difficulty relaxing, and interestingly, anger. I'll assess a lot of kids, and the parents will say, we think it's anxiety, but we're kind of not sure because our son Johnny is just really losing his temper at home, and yelling and swearing, and he's even hit a hole in the wall. It's really not like him. And what you'll usually find, or one indicator of whether it's anxiety or mood related, is does that behavior exist outside of the home? Kids who have anxiety, adolescents, young adults, they do not want to externalize or act out outside of the home. They're doing it inside the home to control their environment. If someone in the audience here, I can't see you, thank God, but if you said, Dan, tomorrow you're going bungee jumping, I pretty much guarantee that I will get sick. I will pretend I'm sick, or I will get sick. I actually don't know. All sorts of things would happen. I'd manipulate, and I'd probably leave the country and change my name, actually, because it's kind of a fear of mine. So no bungee jumping in the near future for me. But other behavioral symptoms can look like depression, like a lack of interest in activities that you once enjoyed. Now, that comes with the depression, but in anxiety, it's more you're not engaging in those activities or those hobbies, typically because it's related to a fear. And we'll be talking about fear shortly, which is at the heart of actually all of this and all of anxiety. And that's not kind of documented as much as I think it should be. Mental symptoms, the thoughts, right? Big part of anxiety. Worry, feelings of hopelessness, thoughts related to, helplessness, hopelessness, catastrophizing. When you're in that anxious state, you're not able to think rationally. And the part that is most challenging is, I think, everyone has some anxiety, right? So because you have some anxiety, like my dad has some anxiety, so he'll say to me, "Oh, I've felt that before. I know what you're talking about. This is what I would do. Just, kind of just think of it this way and just relax." And that's different than an anxiety disorder, which is an anxiety disorder. Really, if you want to boil it down to its purest definition, is I can't control that shit. And I wish I told my dad, if I could control it, I would. I'm not stupid. Now, at 13, 15 years old, I didn't have the confidence or maybe I had the language, but not the confidence to say that to my dad. But it can get to that point where, suicidal thoughts, if your fear and your body's response feels like it's the end of the world, and you don't see any hope out of that cage and dictatorial state of living, sure, you might think of suicide. You might use it as a threat, or you might think, my life's not going to get better. I'm going to live in the state of paralysis forever in this psychological wheelchair. Why not end it? So something that used to be always just sort of associated with depression, and it still is, of course, but it's very linked to anxiety as well. I'm not going to go too much into each of these anxiety disorders. I might go into a few that you might be less familiar with. Separation anxiety, typically with younger kids, younger children, obviously a fear of being away from their parents and needing to know where they are when you're coming home, a lot of frequent calls. I'm interested in separation anxiety because, well, one, it's very treatable, like most of the anxiety disorders, which makes me happy. But the other, it's often a precursor or a predictive variable of social anxiety occurring later in life. So if you're a parent of a younger child that has some separation anxiety, treating it at a young age, ideally pre-adolescence, is optimal. Selective mutism, a student, and I refer all patients, clients as students, a student that basically selectively does not speak or might speak very softly. So they typically feel very comfortable talking to their parents or family members they're familiar with, comfortable with. But when it comes to certainly someone new that they're meeting, or usually a classroom situation, they really don't say anything. Related to anxiety because it's related to fear. It'll all lead back to fear, as we'll be talking about throughout this. Panic disorder, I think you guys know what that is, and we'll talk more about that. Agoraphobia used to be thought as this fear of open spaces, a fear of, well, the definition is a marketplace, but that's because, in ancient Greece, the only place that the 4% of people that had this disorder, the only interaction they had outside of their homes was the marketplace. But it's not a fear of that. Obviously, it's not a fear of open spaces. Really what it's a fear of, it's a fear of being in a situation you can't escape easily if you're anxious. It's a fear of being far away from a safe place or a safe person. Now, anyone that gets any anxiety disorder, whether it's any of these, panic disorder, agoraphobia, generalized anxiety, if it gets severe, they're going to have agoraphobia to some extent. Agoraphobia isn't just people that are kind of housebound and become hoarders and never leave. No, agoraphobia is I have anxiety is pushing me to create or circumscribe my environment and my life to work around the fear that I have of being anxious and being able to escape easily without being noticed or being embarrassed. You've heard of the fight, flight, freeze response. There's also a self-sabotage kind of way of responding. There's a play dead way of responding. Now I see that more with generalized anxiety, perfectionism, kids who are really behind in schoolwork, and they might be very capable, but they get so far behind and they've dug themselves in a hole. And they're thinking, okay, I'm here. How am I going to get back to there? And then they start staying up later and turning in things later and not doing those assignments. And basically, they found safety in their paralysis. The safety of going nowhere works in that moment. Panic disorder, not the most common anxiety disorder, but the stats, 6.2 million people, and this includes adults, so this is all ages in the US have panic disorder. Social phobia is the most common. 15 million adults and children have social phobia. Social phobia I have two subspecialty areas, social phobia and then also interventions, which I'll mention later. If there are questions about these specific disorders, we can speak at the end. I feel people are very knowledgeable about these anxiety disorders now that I don't want to waste time kind of talking about the diagnostic criteria. I do want to mention perfectionism because it has become a major thing. I actually wrote my dissertation on social anxiety and perfectionism, as other people were writing about eating disorders and perfectionism. It was always seen as this kind of positive trait or positive way of thinking and working, pursuing excellence and perfection, and really what we found is that as perfection is never attainable, and it's so highly correlated with psychological conditions and disorders, it's typically becomes maladaptive, especially with the adolescent population or children going from preteen to teenage years. Typically, the perfectionist is intelligent, hardworking. They want to do well. It's just that want and drive needs recalibrating, and they may have sort of found that they haven't needed to study hard when they were younger. You'll see kids 6th grade through 10th just doing great, and then suddenly they not going to school, and it's like parents say, well, I don't get it, he was just fine a year ago. And there's usually a number of forces and factors that play a role in that, but one is they got used to not having to do homework at night. The other, as they get older, the expectations increase. And perfectionism, the strength and disabling potential of it is a lot down to the expectations we set, the degree to which we're self-critical if we don't meet those, and the family forces, the family expectations, the cultural expectations. A quote, striving for excellence motivates you. Striving for perfection is demoralizing. Really in line with what we're seeing with maladaptive perfectionism. I've kind of addressed this. Perfectionism can really quite quickly turn into procrastination like you've never seen before. You can see someone who's just always gets their work done, and straight A's, to a nocturnal sleep schedule, to being a master procrastinator, to being completely paralyzed. Now, I may reference kind of levels of anxiety because I work in an intensive day program. We also have a customized intensive, but these kids are more impaired by anxiety, so some of my references will denote that severity more likely. So this cycle of perfectionism, you do nothing, you feel guilty, there's anxiety and symptoms of anxiety that comes with that. It impacts retention, recall, motivation, and then you feel powerless, and then that cycle continues to the point where, let's avoid school, or and there's many steps before turning in assignments late. There's lots of examples or reasons why people turn in assignments late and leave it to the last minute. There was a great study that was done, I think 2 years ago, that showed that kids that turn in assignments like the night before, they spend 3 hours like really working on it, they've actually started to get some euphoric kind of high or benefit from that. So it can look like, from the observer's point of view, why are you putting yourself through this, hellish experience, and it's horrible to watch. But it's conditioned over time. And then also they have an excuse of, okay, if I don't do well on it, there's a reason. I didn't get to it till last night. So there's all these sort of psychological variables that play a role in perfectionism. So when does anxiety become a problem? All anxiety disorders, or all anxiety, is on a continuum. So, there's appropriate anxiety that we all have, most of us have. It helps to protect and serve us against real danger. Then there's the anxiety that starts to control, dictate, influence decisions, the anxiety that I knew personally and that I devote my work professionally to, where the symptoms are frequent, they're intrusive, typically visible, but not always. They've got to that point where they impact a lot of different areas of functioning, where it can certainly look like ADHD, and a child will go from feeling really helpless with their anxiety because they can't control something that they feel like they should. What's hard about anxiety is you don't experience it all the time. So it's like, okay, last presentation I did, I'm using this as an example, I did great. Why am I anxious in this one? And it makes one think, and kids think this all the time, I should be able to control it if I could control it last time. But the reality of anxiety and an anxiety disorder is that you don't experience anxiety all the time. There may be situations and scenarios that increase the chance of its onset, but it doesn't discriminate in the same way that some of us kind of non-sufferers think. So some key tells. What would you look for as a parent? I think first and foremost, you're not necessarily looking for anxiety. You're looking for, is my child struggling? That's what I feel. Not what I've learned as a professional. I've learned that as a parent. You're not thinking diagnosis at that point. You're thinking, my child's withdrawing. They're in pain. Maybe their grades are dropping. They're falling behind on assignments. They're not connecting with peers as much. Those factors could be a sign that it's anxiety. But out of the 30 or 40 people that we assess every month, only 30% is anxiety, in the sense where anxiety is the core issue that needs treatment, versus anxiety being a symptom of something else, like ADHD or depression or learning disabilities or autism or the spectrum disorders. So it's a common disorder, but teasing it out is extremely important. There are some things, though, that are usually, real clear tells. Like, if a student is increasingly asking to leave a situation where they may have to speak in front of others, or some performance-related activity. And then a big one is obviously visible signs of anxiety. One of the first things I ask all the students that I'm assessing and parents is, what does your child's anxiety look like? Are the symptoms visible? If you ask them what they fear in life, are there specific fears, or generally, what would they say? Might be, I don't know, I've never really asked them that. But maybe it's asking specifically, do you have a fear of evaluation? Do you have a fear of judgment? Do you have, these are maybe clinical, a little too clinical, but evaluation, judgment, rejection, abandonment, fear of the future, the fear of not living up to the expectations that you have or you feel that we have as parents. A fear of getting to school, attending school, graduating, a fear of getting worse, a fear of getting better. That's a common fear right now. hell, if I get better, I'm going to have to maintain that. I found some safety in my pathology. It's giving me an excuse sometimes, not that I can control it, but it's an excuse for why I am so stuck and so behind. And a big thing we see in treatment is that point where they've learned these skills and they've habituated them, and they're seeking out opportunities to experience anxiety, to nurture resilience and nurture grit, and wonderful stage in treatment. But then they're still afraid of letting go of the OCD that has provided them so much comfort, the compulsive behaviors that have provided so much comfort in the past, or the social anxiety that they could hide behind, and that they won't be able to use when things get hard in the future. So I'm going to talk about variables of influence because I think it's really helpful for parents, and we're kind of at this assessment phase of the presentation where we want to know kind of what anxiety looks like, how can we assess it, what the experience is like. What I really would love the parents out there or clinicians who's ever out there, I can't see obviously, but is to come away of what the experience is like for the child. That's pretty much my variable of impact as a human being with these kids, is my experience and the degree to which I can connect with them and find that attunement on an emotional level. And knowing these variables will help. So big A is an anxiety disorder. Little a is anxiety that everyone has. It's fleeting, it's non-intrusive. But the big A is anxiety that starts to control and dictate. Threat is a factor of anxiety, because anxiety is a series of symptoms. As we talked about, there's physical symptoms, cognitive symptoms, emotional symptoms, behavioral symptoms. But what I think is really important is the fear that's behind that. Because if the fear isn't there, my theory is that it's rarely anxiety. It could be something else. Now, the child might not know. Your child might not know that it's what the fear is. But if they don't get to that conclusion, there are about 14, 15 different medical conditions that it could be. I want to tell you all that over the last 2 to 3 months, 4 or 5, which would be, 4 or 5 probably actually percent of the clients who really presented with like clear OCD or panic disorder had medical issues, whether it's related to the thyroid, tinnitus, or immunodeficiency, or I've got a whole lesson sheet on that. So it's really important to get a medical review before kind of jumping in, assuming it's anxiety. I go into every assessment assuming it's not, because I obviously don't want my bias and my expertise to become a bias. So threat, some danger. There's perceived threat and there's real threat. COVID, first time, maybe not the first time in our lives, but it's a real threat. I hate to say, I wish we had COVID when I was in high school, because I would have had a really good excuse to not go to school. I had to make these very elaborate excuses in London in the late 90s, when social anxiety was a weakness and something you had to snap out of. There's a cost usually, something that you're going to lose. There's some value with, if the child doesn't really care about the situation, they're less likely to be anxious. So they care about the perception of others, how you guys are going to perceive me, or the imminence of that threat, perceived or actual. Is the SAT exam tomorrow or 2 weeks from now? The probability of experiencing that anxiety, or the probability of that threat. Probability is a big one. If a child goes to a social event and experiences high anxiety with some friends, the chances are that if they return to that same situation, they're going to get anxiety again. It's a higher chance. So that variable, that number in that variable is higher. It doesn't predict or predetermine anxiety in that situation, but it is certainly a factor and not a moderating variable. What's most interesting to me, and I don't know if you can see my cursor on my slides here, but S plus X for F. So F is frequency, and this is the treatment part, which is what I love about it. So strategies is what you learn in therapy. Now, there's a lot of wonderful therapists doing great work with treatment and anxiety, and we're fortunate that we can have access to students daily or 3 times a week, because repetition of treatment really helps. But the X factor is the experience that they've certainly had in the past, the new experiences they're forging, and the amount of exposure that they're doing. I use the example of public speaking as being, well, it is the most common fear in the world. And the reason I think it is, or as a clinician, I see it this way, is because no one does it frequently enough. I still do not love public speaking, but if I did it every day, I could probably get it up on a stage, tell jokes, and do improv, and a lot of our kids could. So frequency and deliberate, kind of directed, controlled exposures, not too much, too soon. It's a scaffolding that courage and independence, whether it's back to school, whether it's communicating more about your day or about your emotions with parents. It's all got to be done in a controlled way with hierarchies across domains. And those domains are of school, family life, social life, and the things that they fear and avoid in those situations. And then frequency, any skill, skills are more likely to turn into habit if you're doing them frequently. We talked about some of the cognitive disturbances, but some interesting findings. Definitely they're very attentive to things like threat words they perceive as critical, threatening kind of facial expressions. Interestingly, kids with anxiety, not just social anxiety, will be able to respond at a considerably faster rate to pressing a button than a non-anxious person with an anxiety disorder to a threat word or a threatening facial expression. Selective memory is a big part. They will remember those times where they had that panic attack, or where they had to walk out because of their symptoms, or the test that didn't go well. And kids will talk about it maybe as almost like a scene of the crime, because they do feel guilty. They feel like this is a weakness. And that kind of breaks my heart. And that's what I really want to kind of get across is, as I said, if they could control it, they would. Yes, they will use excuses and strategies, but they're doing that because they're trying to live with an untreated condition. Anxiety obviously affects memory, attention, speech, language, executive functioning. If you're being chased by a tiger, or I'm doing an exposure and I'm getting someone from the 3rd floor to the 5th floor to the 7th floor of the Empire State Building, going from conversational exposure to imaginal exposure to virtual reality exposure to in vivo. This is our step approach. When their anxiety is high, they're not going to be able to engage in conversation and remember things as well, because they're in this threatening fight or flight response, which is what we want. Now, parents, and I'll give you some strategies very shortly, it is not my intent that you become that therapist, but you can certainly become a facilitator or a partner in treatment, and a parent coach to know what are the variables of influence that trigger the anxiety. And we'll actually get to that in a slide. I don't want to talk about variables of influence yet because they are important. There's a lot of related issues with anxiety. There's a few myths, the chicken or the egg with anxiety and depression. Oh, you can't tell which came before. You can actually, I think. I won't spend time talking about it, but depression and anxiety, by definition, cannot occur together. It cannot in the same moment. Anxiety is an activated state, and depression is primarily a withdrawn state. An apathetic state, withdrawn. That being said, you can feel helpless because of your anxiety and really trapped because there's no way out. And of course, you'll feel hopeless and develop depression, or more likely to. It's possible, but more rare, that depression precedes anxiety. The only time I think I see that is when depression, someone's gotten successful treatment from depression, whether it's medication or through therapy, and they've been out of school for a while, and then they've got to return, and there's anxiety and fear that's developed from those expectations that emerge from treatment and recovery. Yeah, so there's physiological symptoms, there's psychosomatic symptoms. Sleep is a major impact on or variable associated with anxiety. Social withdrawal will happen across all the anxiety disorders. A really important thing to look out for. A hard thing to assess right now, right? But if they were doing, Zoom get-togethers or whatever social media platform they were to socializing with friends, and they're not, that is something to look at. Mood-related impact. I mean, anytime a health issue, a mental health issue controls you, you're going to have lower frustration tolerance. You're not going to be able to regulate emotions. One aspect of anxiety that I see a lot with the kids is they're less likely to do drugs and do substances. They certainly spoke cannabis and do more teenage typical things. But on the higher end of the anxiety spectrum, they're more likely to be junkies of homeostasis, which is, homeostasis is our natural innate desire to feel that internal locus of control. And they're more fear averse and risk averse. Now, that doesn't mean that someone that is partying and taking risks does not have anxiety, but it's actually a lot less likely. They may, speak to it, but I don't know, more often than not, it ends up being something else. I'm going to flip through here because I think, 743. Misconceptions. I mean, there's still the stigma about anxiety and mental illness, but it's getting better. Anxious people or depressed people, they're not attention seekers. Trust me, it's the last thing they want is attention. There's a lot of stigma for parents, and we see that a lot. And I process a lot of those issues and feelings that parents have that, I wish I had done this, or if I only had parented this way. If there was a direct, clear causal pathway of if I parented this way and parented this child in the same way, that one, my child would not have anxiety. If that was the case, I'd probably be out of a job for one, but with the anxiety, the rates of anxiety would be absolutely different. And it just doesn't work that way. There's a multiple sort of origins. And we look at a biopsychosocial origin. There's a genetic component. There's other health issues that could be going on, social forces and factors, from bullying to peer rejection, to divorce, family circumstances, side effects on medication. The last 2 assessments I did, students had really bad anxiety and OCD. One had PANDAS, which is an autoimmune issue that's actually treated with antibiotics, and the other was a byproduct of traumatic brain injury. So health issues can cause anxiety is where I was going with that. So experiences, traumatic social memories can definitely trigger anxiety that was probably going to be there anyway. I'll briefly go over some of I'm really interested in the twin studies and the concordance rates, and, looking at identical twins that grew up in the same home, and then identical twins that were separated at birth. And that's how we can find out the genetic kind of component in the etiology of the origin of anxiety and other disorders. I couldn't find the other slide breaking it down by anxiety disorder, but bipolar, as you can see, basically a genetically passed on disorder like schizophrenia. Anorexia is 60%, 40% being, kind of social forces. depression, 37%, and all the anxiety disorders kind of fall below kind of 45%, between 15 and 45% in the slice of the pie that's biology and genetics, basically passed down by parents. So my mother has social anxiety and agoraphobia. My grandfather did. It was a problem for my mother, but it wasn't for my grandfather because he lived in rural Sweden and there was no social situations he had to face. So there are cultural factors and forces that play a role in whether a disorder becomes a disorder. Anxiety impacts the entire family system. I hear, and there is that judgment of like, I parented my child this way. And if you're just being tougher with your kid, they wouldn't be avoiding like this. And parents do the very best that they can. And it happens gradually, if they're struggling and they're avoidant and you have become kind of overprotective over time and become accommodating or enabling, that happens, not only over time, but it happens for a reason, because you see your child struggling and your innate, inclination is to protect them, is to, decrease their anxiety, improve their mood, rationalize and fix problems for them. I mean, it's really hard not to do that. I'm really worried about how I'm going to be able to do that, to be honest, even though I know this stuff. So the real goal is giving them opportunities to tolerate discomfort, and to sit in that anxious place. Just as a therapist, a CBT therapist that's using exposure, the goal is to, in a controlled way with some time limits, elicit and evoke that anxiety. And while a parent might not induce that anxiety, a parent can absolutely seize that 15-minute period of not rescuing, not providing reassurance, not fixing the problem for them, basically letting them crash and burn, because there is tremendous value in maybe failure. There's value in, God, I've got to figure this out myself. And really what we're doing here, we're nurturing resilience, confidence, self-reliance, a greater degree of interdependence between family members. Things have changed a lot over the last 20, 30 years, as you know, and it's not uncommon for parents to be very involved, and I say this with no judgment, but very involved in advocating for their child's grades, for making sure that they get, the best attention from teachers, but we've really got to prepare them to, if we want them to become resilient, they've got to fall a bunch and get bad news and have to advocate for something themselves, and learn to do it by themselves, learn to do those things for themselves, develop those skills, versus taking those opportunities away. So this will be pretty intuitive, I think, for a lot of you, but how does this family accommodation work? It sends a message. How I'm going to frame this is what I have heard from kids, because that, I think, has the value more even that's in the research maybe. But I've heard a student say to me, typically after treatment, with an over-involved, loving, very sweet mom and dad, they were so involved in my life and were so afraid of me to go to treatment, that was the case in this situation, that I really believed that there was something to worry about. They didn't want me to go to residential. They were worried it was going to traumatize me, as I did back then. But I remember feeling like, if they have those fears and doubts, there's something bad that could happen. And the other thing that kids often think is, there's something deficient in me. You're so involved and you're helping me with this and protecting me from this, telling me about that, and continuing to talk to me until I feel better. And that feels good, but then there's a part of a child's mind, they may not know it in the moment, but there's something deficient in me that you need to provide this extra attention for me, as instead of my sister, let's say. Now, not all our kids are the same. One child may need help, but there's this point I see in that trajectory of individualizing support and time across kids, But there's that point where it has to be really kind of pull, one has to pull away or reshift the strategy. And some of those strategies, well, the global kind of approaches is certainly validation, empathy, with the goal of eliciting self-efficacy, which is, the ability to do things for yourself, fostering independence. Some traps. Everything will be okay. That's reassuring. Example of reassuring. Example of avoiding. The fear of triggering anxiety. Okay, you don't have to go to the baseball game. I know you're not feeling well. We'll go next week. Assisting, typically with decisions, with plans, and that often comes and linked with modifying and all the plans that the family has. If a family has a child with severe anxiety, it's not uncommon for a lot of their world to revolve around, living and coping and serving that child's condition and what they're trying to control. Assuming your child's responsibilities could be, and again, any parent's going to do this just by the nature of being a parent. But let me help you with your homework. What becomes not supportive becomes, I'm going to get it done. And then it could be, I'm going to get it really good, versus maybe this is a good opportunity to try to turn in a C or a D assignment, to use this as an example that some things are extremely successful if just completed. Tolerating abnormal behaviors or conditions. It could be a child yelling, swearing, behaving in a way that they wouldn't. Most anxious kids are bright, sweet, sensitive, and suddenly they're terrorizing, maybe even holding the house hostage. And one tolerates it because, a fear of, I don't want to rock the boat. I don't want to make him worse. I don't want him to cut himself. I don't want him to jump out the window. I don't want to traumatize him. Yes, sensitivity is needed, but there's a language and approach that, if I had a lot more time, I'd go into it at greater depth, but I have a lot of resources on this. So I'm hoping that we have, I'm sure we have all your email addresses, so I can send out some workbooks and resources that you can use as therapists or parents. But basically, it's teaching teens to handle uncertainty, to handle the unknown. What's anxiety about? It's a fear of not being able to control the external world, predict or control the external world, one's internal emotions and symptoms and physiology. It's about trying to accurately determine danger and threat, and trying to read the cues among family members and among parents and siblings. So what do we need to do? We need to, we don't want to avoid eliminating all risk. We want to avoid that. We want to eliminate some risk. This is not, right, child's 18, throw him out of the house. Got anxiety, get a job. No, those draconian days are over, thank God. But teaching them concrete skills. Avoid asking why. It's fine, like, when you're asking about what's going on and why they might be anxious, not why with him. Like, tell me about the story, like who, what, where, the context. Really, the way I see when I'm talking to a child is, help me, take me there, not just in my mind, but emotionally. I want to be right next to you in that experience that you had. I don't care about why. I tell you what, because we can't fix the why. But I want to know what it's like, because it seems really tough. And I don't think I get it as your dad, and I want to get it. And I'm so grateful for this time to just help me understand it, because it must be really hard. Would be an example of a little role player. When someone comes to me outside of the therapy room, I'm just like, fix, move on to the next, right? Try not to do that. Now, there's some things that there is a strategic solution. But I'm always afraid, maybe with my wife, it's like, okay, is she asking me because she needs strategy to resolve, or am I meant to just be present and acknowledge emotion and just be there, right? And also with clients. So I've discovered and learned, not just as a therapist, but as a spouse and a parent, is it's okay to ask, what do you need from me right now? Because whoever's going through the distress, it's real for them. It might seem out of whack and irrational, but that rationality of it can be figured out later. That emotional connection can turn into you being an emotional anchor. Pretty obvious, some of the avoid, catastrophizing, allowing to make mistakes we've talked about. Modeling resiliency is really important. I'll be honest, I saw a lot of anxiety in my home environment. Our lens to the world is not exclusively, but a part of it is through our parents, especially at a younger age, and then social media too. And there's a whole other talk on social media and anxiety, but something that, I've seen a parent say, and I didn't teach them this. I learned this from dad that I was working with, and it was related to COVID. He said, and the kid was very anxious about COVID, and he said, I was really worried about COVID. I was worried about getting it. I was worried about, what would happen. I'm older, but I did a lot of research, and I spoke to some professionals. I spoke to some health professionals. I spoke to some colleagues. I read an article, and I'm not worried. We're going to be cautious, and we're going to, follow the guidelines. But, I can't make you not worry, but I want you to tell. I want you to understand that I am in a place where I feel confident that we're going to get through this. So it's really kind of communicating that confidence and a sense of calmness, I guess. But somehow, and I didn't use a great example or do a good role play in that situation, but emanate that emotional comfort, even if you have to fake it. Model resiliency. Yeah, I think people do the best they can with that. We all are imperfect in regards to that. Some of these kind of are a little not repetitive, but they're related, and I could go into them. But I think I've got an hour, right, Kirsten, and then about 15 minutes of question time.
Yeah, I think we can start wrapping up this part of the presentation, and then we can open it up to questions from the audience. What we were going to do is, instead of having everybody unmute themselves, if you just want to type any questions that you might have directly into the chat box, I will moderate the questions and read them out loud so everybody can hear.
Just to know, everyone will be getting the slides. As you saw, I didn't get to about 5, but there's other resources that are available too.
Absolutely, and I just want to make a quick announcement. If you do wish to receive a copy of the slides and the recording of the presentation, I put my email address in the chat, so feel free to email me directly and I will get you a copy of that. You can also just chat us right now, or chat me privately and put your email there so I can get you the resources. All right, so let's open up the chat. Does anybody have any questions for Dr. Villiers about anxiety or any of the things that was presented on today?
Hi, I do have a question. My daughter constantly tells me that she doesn't want help, that she's always pushing me away from the situation if I see something that's concerning, or I try to help her. She's constantly saying no. She doesn't want to talk about anything, and she never wants to accept my help. And yet I do think that she, she wants to, you know, achieve her goals, and she works hard at, working towards her goal. But I think she goes about it, I don't know, standing from the outside, it looks like she struggles a lot. And I offer, my opinions, my suggestions, but she's always telling me, no, 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 I got this. But she is struggling.
Mm-hmm.
So should I just back off and just, like you said, let her, fall completely, you know, um, on her face and just let her deal?
Yeah. A good question. So, a lot of these strategies are when you kind of know that it's related to anxiety, fear, and avoidance. And there's usually some therapy that's happened, and I don't know if she's had therapy, but she's in a place that she's struggling. You want to help. She doesn't want to necessarily open up to you, which doesn't mean that she's not going to open up to someone else or isn't able to get that help. Mm-hmm. It's very hard to open up to parents. It can be easier when you're on your way to getting better, or certainly a lot easier when you've gotten better. It's easy to talk about a problem that you've overcome, but I think it's finding a therapist or some coach that could just have some initial conversation. Is she resistant to treatment? Therapy?
She was in treatment, but I really don't know what they discussed. And she would never open up to me after treatment. So she just mm-hmm. recently stopped treatment. And I offered for her, I suggested that she go back. And mm-hmm. she says no. So, all I want to do is help. And in a loving way, I just want to support her. I know, I know she's going through something, and this is obviously what it is. I learned so much tonight. Thank you very much. So, I'm just trying to support her, and I don't know if I'm hurting her by being so adamant about trying to help her.
Yeah.
I'm sorry.
Yeah, sorry. Go ahead.
She recently had a panic attack, and it was the first time I actually, saw it. I witnessed it. So she used to tell me that she used to have one, but I never witnessed one. And I was really scared. And so I'm always afraid. I'm working on pins and needles, like thinking, oh, she's going to have one. Is this going to lead into something worse? She doesn't talk about it. So that's why I'm always trying to get her help, because I just don't want her to get worse. Yeah,
sure. And, I'd obviously, recommend, and I think you said she was seen the therapist, but I recommend. How old is she?
16.
16. So I'd recommend, having maybe another therapist, or speaking with the therapist to try to set up some agreement where she can share. Because I feel working with kids, it's really hard not to work with the parents. I mean, anxiety is not an individual issue, or depression it's a family system issue. And that doesn't mean that I'm going to share with you sort of secrets or details that that she shared, that if were important, I'd get her to share them. But it would be very hard to make this a successful, even transformative experience, especially a transformative experience, without kind of partnering with you and us working together to some extent, because you're in the dark, and that's not only a scary place to be.
Exactly.
So a therapist, and I could give you a short-term strategy that I don't really think could harm, do any harm, but is maybe trying a different mode or method of communication. So perhaps writing a letter of, I'm not trying to impose on your privacy. I'm not implying that I can fix this. I just, would love to know kind of what's going on. I know you've got it. And there's such a big part of me that trusts that. Mm-hmm. But I'd love to know a little more if there was a way you could maybe tell me that in any way you can, whether it's a text or talking about it, in a few days or something. See what she says. I mean, how do you think she would respond to that?
Okay. Hopefully she'll be open to it.
Yeah, I would try that. And yeah, try a different mode of communication, and don't be afraid to kind of express why you want to know in an honest way. You know,
Right.
yeah, you're concerned, and she doesn't want you to worry. You know, she doesn't probably realize the benefits of if she shares some things that you're going to probably back off. She's
Right.
not seeing that. So maybe that's, you know, I want to give you that trust and freedom. It would help if I knew a little more.
Okay, great. Thank you. I appreciate
Sure.
it. Mm-hmm.
Thank you, Dan. We also had a couple of questions coming in about how anxiety impacts education. So there's one here. How would you describe the educational impact of anxiety? And then I'll just scroll down. There was another one that was also related to school, but can you speak also to the inability to pay attention during lessons and engage in class due to anxiety?
Mm-hmm. Yeah, so I mean, struggling with attention and executive functioning issues could be driven by ADHD. It could be driven by anxiety and other things, but assuming it is anxiety, and let's say you know we or you know that, there's a lot of cognitive interference that comes with anxiety. You know, there's a lot of thoughts that come in one's mind. You know, I'm focusing on one thing, and whether it's a perceived threat or related to a fear that I might have, or how much time left is in the class, or God, I didn't get to that assignment, and I know they're going to call on me, and I didn't do the reading, and it could, you know, if it's related to a fear that's going to impact, you know, one's ability to focus on the teacher and the blackboard at the screen. So that's sort of in the classroom situation. Testing situation plays a huge role. I mean, if your heart rate is going at 120 beats per minute, it's very hard, you know, A, B, C, D, E. I mean, God, you know, 2 minutes ago or a minute ago, I knew that A through C was totally wrong, and it was just D and E. But now I'm like, you know, it just absolutely creates a lot of cognitive noise and interference. So it impacts retention, recall, focus, and really the ability to function as an effective student. You will find it's not always across all classes, depending on the teacher, safe teacher, non-safe teacher, the size of the class, the nature of the assignments. But yeah, anxiety plays a huge role, and it's one of the areas that we look at in determining, is it anxiety, is it ADHD, or how are they maybe both working together in an unconstructive way.
Thank you. We had another one here, and I think we touched on this a little bit at the beginning, but how do you differentiate between true anxiety symptoms and just kind of regular teenage behavior?
Yeah, good question. I forget who it was. I think it was a parent who said something very similar. It's like, how do I know if it's like my kid's just anxious or just lazy, or something like that? And it kind of reminds me of that. It really depends on kind of so many variables, right? So variables of influence, the context. I probably need an example to be able to answer this accurately. But if there's this palpable distress that comes with the communication, you know, they're coming to you and maybe an excuse to not do something, or they're hysterically crying and freaking out about something. What are they freaking out about? Is there any primary or secondary gain from freaking out? Like, what is she getting from it? Maybe it's just, I don't want to go and I want to stay and watch Netflix for 5 hours. That could be the case. You just want to rule out that it's not something that she's avoiding. You know, is there something that she was going to do that might trigger anxiety? So I think it's just looking at the context, not immediately assume that it's not behavioral, or just she just doesn't want to do, he or she just doesn't want to do something. But that sometimes does happen. It's like, oh, I'm really anxious about something. No, they want to play 5 hours of video games. So there's no easy answer for that without an example, but definitely taking through, you know, take the empathetic approach and hear them out, but don't let them off the hook in really digging deep on the reasons, because then you'll know it'll give you more data on the genuineness and legitimacy of it.
Thank you. Another question here. When you have a child who gets caught in anxiety loops, obsessive thoughts about a fear, how do you help them break that loop?
You just say, stop it. Just kidding. That's what they used to say in England when I was a kid. Definitely not stop it. If they could, they would. So when you're in treatment for anxiety that's severe, there's things that I might recommend for right now that we might not in that environment. But that's got to be a controlled environment where you're, doing exposure work gradually. But if someone's in a panic state, if it's thought related, distraction is appropriate. Breathing exercise is absolutely appropriate. One of the best strategies I've found and I've discovered just along the way is, I've had kids come into my office panicking, panic attack, someone calling on the phone, panic attack. I just want you to go around the building and run 3 times, 4 times, wherever they are, the house. And I'll be on hold, and I'll be here when you get back. And what's happening is they're basically like catching up with that fight or flight response. They are running, but they're not really running away. I'm telling them to really run into their anxiety, because so it's sort of like half escape, but also half like face the lion. And what's happening something mentally is they're justifying the symptoms that they're experiencing. Oh, why am I so distressed and upset and anxious? Oh wait, I just ran around the building 3 times, and this crazy British therapist just told me to do this. If it's more so it's sort of a panicky, there's some variations depending on what they coming to you with, but going for a walk. If you've had some and breathing exercises, muscle relaxation exercises. I've got a guided imagery, and guided imagery can be done. You can go online and find a script. It's not hypnosis. It's just taking them on the journey or giving them a resource to do that themselves. And another approach, if they're more advanced in treatment, is instead of a means to decrease and a healthy means to decrease and divert, it could be, let's see this as an opportunity to experience this. Let's be mindfully aware of this moment and these symptoms that I'm having. Because the more you often push them away, the more they'll push back. I often tell my clients, bring it the hell on. Like, I want you to try and increase your heart rate. I want you to try and increase those thoughts. Let's make them worse. Let's make them combat each other. Let's schedule some panic between 3 and 3:30. They can't, it's very hard for them to do it. I'm not saying that you go there, but I'm saying that there can be some flexibility, which you kind of, strategize and create a bit of humor with, with the serious, validation and empathy that's there. Because you're just trying to find strategies that work for the individual. And I think sometimes the best way, around anxiety is just straight through it.
Thank you, Dan. Before we move on to the next question, I just wanted to say again, if anybody would like a copy of the slides or the recording, please email me directly or send me a copy of your email address so I can get those to you. And I also wanted to give a shout out to Christine Mahoney and the Chatham Schools for hosting us tonight. We really appreciate all of the work that you did in putting this together for us and being our host. So thank you.
Yeah, thank you, Christine, and everyone who was involved. It was just a great pleasure to speak with all of you. And I just want to end, part of my role, I am part of admissions with the Anxiety Institute, but most of my role is serving families as a consultant, as a facilitator to get help. So I consult with schools and therapists and families, and usually that initial call is there's no cost to that. It's serving as sort of an anxiety consultant as we build a team to make an informed decision, or to help you make an informed decision. So my cell phone number is on there for a reason. It's because I care and I want to help.
Thank you, Dan. We have a couple. Oh, sorry, go ahead, Christine.
No, I was just going to thank you both for everything. You guys have been amazing. And thank you very much for everything that you guys have done. we're really appreciative at the Chatham School District as well as the consortium to have you guys a part of our presentation tonight. So we really appreciate it.
Thank you.
Absolutely. And then we can wrap up with a couple additional questions. So we had one question: what is your opinion about medication?
My opinion is just one person's opinion, one therapist's opinion on medication. I think the research will say medication and therapy is the best course of treatment, but depends on a number of factors. How frequently that person is in treatment. That research was done on a client going to therapy once a week. When you have a client with moderate to severe or even mild anxiety, it's hard to turn skills into habits. It's hard to desensitize the anxiety and fear that they're feeling, and do some of the work outside of the office and engage them in the full way. So medication can serve as often as a necessary or very valuable adjunct to treatment. I've espoused this less, but I'm starting to become a little more open-minded, is that there are situations where someone presents with OCD. They go and see a psychiatrist, they're on meds for 3 to 6 months, and their OCD goes down. I don't see too many of those because I work at this sort of higher level. But my basic feeling is exhaust all therapeutic options, go to the core, try to treat it, use medication if it helps someone get to treatment. But the best outcomes, the best experience is facing the hell of treatment without medicine, in my opinion.
Thank you. We also had a couple questions about how to help kids kind of de-escalate their own behavior and how to help them deal with angry outbursts or, when they have to do something that is against what they would like to be doing.
Mm-hmm. Yeah, I've been asked that question kind of a lot, and I don't think I've found a good answer, or I know a good answer. With anxious kids, when they get angry, it's usually helplessness, frustration, not getting what they want, typically related to control their environment because they can't control their internal world or control whether they're going to have to do something. It's often a lot related to school refusal and wanting to get out of things. But if I'm talking to the child, the few that do come to me and say, help me de-escalate or help me calm down, or in therapy, I'm certainly training them if I have that relationship. Some of the same strategies. I mean, I'll do process, but I'm not a big process person. And not that I don't establish that relationship, but I mean, you can process, and for years on end and develop all this insight. But if there's no behavioral change, it's just, it's very limited. And so I'm all about behavioral, developing the insight and awareness of certainly the emotions. I use grounding exercises. I use DBT strategies. I'll go out of my box of knowledge and learn. I learn a lot of stuff from other clinicians in ways to grounding someone, regulating that emotion, finding a healthy diversion from that anger. A great strategy in that is removing oneself from that situation of conflict. But it's important it applies for the child and the parent. It could be easy. Well, a parent will say, I was just there because I really wanted to kind of help, but just being there can inadvertently enable sometimes. And so, there are a number of strategies, but it's I would say it's not really my expertise. I've got some when someone's panicking and someone's trying to predict and control the environment and get what they want from their parents. When I'm talking to the child, I try to get them to see that after they've calmed down. So I'll take them through guided imagery, diaphragmatic breathing. I'll take them through a progressive muscle relaxation exercise. I'll get them to do some mindful awareness. I'll get them to take their pulse rate and count it and tell me the number. And I'll say, in about 20 seconds, you're probably going to notice it's going to go down. can't guarantee it, but I actually just want you to focus on that and that alone. So something that can really like just hone them in on something else so different. Or I've used strategies where I got to tell you something horrible that happened to me last week. And a kid is like, what do you mean happened to you? I'm the, the client. So there's some paradoxical interventions. There's different ways that one can approach and, be creative. As a parent, you can be more creative. It's like, did I tell you about the horrible day that I had at work last week? Depending on the age of the child. But, kids still think that, parents are more inclined to sort of tell them about the great days and the successes. And so there's, in those moments of crisis, some distraction and diversion and temporary avoidance is okay, because you're trying to stabilize. Sorry, not a perfect answer there or anywhere close, but.
No, thank you. That was great. There is a couple more questions. This one's a little bit more specific, but how can I help my children feel less isolated being new students? They are both feeling anxiety and depression from not knowing anybody. We just moved about a month ago.
Mm-hmm. Yeah, moving is a big life change, obviously, especially with COVID. Everything that was sort of predictable in one school is not now. I'm all for controlling the variables as we do in treatment. Those variables are the pace of school, the content. If you're working with a therapist, there are potentially accommodations that are healthy that can be done. If it's not at that level, certainly it might be really trying to push them in. But a parent can scaffold just as equally just as effectively as a therapist sometimes can, and obviously best working together. But don't be afraid to scaffold. Don't be afraid to, it could be driving to the school. It could be to get close. It could be making a lot of effort to get one person that through a family friend or a church group or anything. I mean, it doesn't really matter. Almost, it's just some social connection that can help that reintegration into school. And then obviously just the reassurance that it's going to take time, and you're going to feel anxious, and it's going to be a tough few days, but I know you can do this. You've done this before, and if it doesn't work out, we are going to get the support you need, because that's not rescuing. That's just, I'm going to be unconditionally here to support and foster your skills, your independence, your social connection, to give you the resources you need.
Thank you. We'll wrap it up with one last question. And I think this is a question you could probably do a whole other talk on, so we can keep it brief. But my 15-year-old has both ADHD and anxiety, and it's been difficult to find a professional who can support him in both. Can you describe the process of teasing out which is causing the issues and how it can be addressed?
Yes, so there's evidence-based assessment measures that can be used to assess anxiety, assess ADHD. Most therapists can provide them, or a neuropsychologist could. With my assessments, that really is delving into the experience. So I talk to a student on the phone or Zoom very informally. I'm not there as a therapist. I'm there as a coach, an interventionist, a facilitator, a mentor. So I have looser boundaries where I can kind of share my own personal experience and talk about. So the first call is often talking about everything but ADHD and anxiety. And then maybe it's at the end of the call, the second call, I'll, in a conversation where I'd be asking about, attention, focus, fear. Some of the differences between anxiety and ADHD are the distraction and, the difficulty focusing, or the sluggish cognitive tempo, the things that you see with ADHD, the organization. It's when it's related to anxiety, you can kind of link it to a fear or a perceived threat. or it could induce anxiety. But with ADHD in its kind of classic form, that distraction is it's just there. There doesn't seem to be. It might create some anxiety when they get behind and they feel bad because they didn't do chores, or but there's this almost emotional detachment at times from the expectation and the duties, or the expectations. Whereas anxiety, it's more emotionally laden, I guess. And attention deficit is sort of a deficit in attention, and hyperactivity is sort of impulsivity and difficulty managing that emotion. But fear is the real big variable under there. Kind of get to that fear variable. Why are they being impulsive? Is it to self-soothe something, or is it just? It's just like this sort of habitual drive. So yeah, there's many ways to tease it out. It's usually done kind of in conversation, assessing how they do in school, socially, not how they do, but what their interactions are like, and certainly how they respond to fear, the symptoms they have, the nature of their ADHD and how it presents, the things that it impacts. But on a most basic level, I would give like a Connors assessment for ADHD. I would give, if you're a therapist, an ADIS, a semi-structured interview, and there's some more formal assessments that you could use. But that's a great question, something I would actually speak to a therapist about. And if I have your email address, I'd be happy to send you this really good article that I'd probably be able to articulate better if it was earlier in the day. But it's not easy, I'll tell you that.
Thank you, Dan.
But you can treat both together. A child can be on stimulant medication and it not always trigger anxiety. They are treatable as independent agents, and then as ones that are intertwined. From my experience, I think about the kids that have come with an ADHD and anxiety diagnosis. Let's say it's about 40-50%. About 15% do have both of those diagnoses. Now that's just one person giving that data. It's not in a journal, but based on that, it's worth figuring out, are they both there? Doesn't mean it's just anxiety, but are they both there? And then if they are, getting someone who is experienced at treating both. And if you need some resources on an expert in that, I'd be happy to provide that.